You are very welcome to this talk. Now, delighted to welcome back Dr. Michael Cohen. Doctor, thank you for coming back again.
Thank you for having me.
And these topics we're covering really are of immense importance to so many people. And the one tonight is a topic I've never fully understood. So in my old age, it would be good for me to learn about this eventually. But working on A&E, I've seen patients, accident and emergency department, patients admitted with migraines in absolute agony. Uncontrollable screaming agony, a really serious condition, and various severities of migraine are suffered by a great deal, a great number of people. So it's really great that you're coming to share your knowledge of it tonight. I mean, did you see a lot of migraines in your practice?
I see a lot of migraines for sure, always have done. And I've also seen ways in which things that I used to use in terms of medications. There's a whole array of different medications that you can use for preventing migraines and for treating migraines. But what I've seen over the years is that things that I didn't fully appreciate, certainly as a medical student or even as a younger doctor. And with time, I've come to appreciate that there's a lot of other things that we can do that can go sort of upstream of the problem. So instead of just treating with medication for the symptoms, we can actually, prepare the physiological background, the soil, if you like, so that, number one, they may have less migraines or less severe migraines, sometimes even almost stop the migraines, and sometimes just make it much more likely that a person doesn't necessarily need medications or needs less medications, in addition to some of the things that we'll talk about in this video.
Really important point. Very often doctors will just treat the symptoms with analgesics or give some specific anti-migraine drugs. And they are good at aborting attacks and reducing the pain. But I've seen patients with all these treatments still in quite bad pain. But of course, always prevention is better than cure. So I really like this idea of going upstream, finding out what's making the water all muddy upstream. And that's much better than treating it downstream. I want to talk about, first of all, the investigations. What investigations do you do when someone comes complaining of migraines, and what's usually missed in standard care? Because what we're doing on these talks really is looking a little bit outside the envelope, aren't we? So, right. So what investigations do you like to do, and what is normally missed in standard workups?
Okay, well, before I talk about the medications and the investigations, I just want to sort of just give people an idea of the scale of the problem, because it's estimated that over 1 billion people worldwide, that's 1 in 8 people, suffer with migraines, obviously to varying degrees and various severities and various frequency of these attacks happening. But it's important that people understand migraine isn't just a headache. It's an actual neurological event. Which we'll get into a little bit more in detail. It's an extremely disabling condition, globally that is. It's even disabling for children. Often children are not recognized to have migraines because they just think, children don't get migraines, but it's become more and more recognized that they do. In the UK, as it happens, it costs the economy in the region of £12 billion a year in lost productivity or time off work. And interestingly, in the last 25 years or so, since around the 1990s, early 1990s, the prevalence has gone up by about 60%.
Has it?
Which is very interesting, because you'd have to think, why would that happen? And I'm sure we can come up with a few theories, which we'll touch upon when we talk about all of these things. But to get to your question about what investigations, first of all, there's the usual investigations that people might get depending on at what stage in their life the headaches, the migraines begin. Some people some people will end up having a scan of their brain, an MRI, to rule out any other cause. And that there are reasons. There are indications for when that's necessary, and there are indications when that's probably not necessary. I'm not going to get into all of that, but I will talk about that's something that really needs to be thought about, and that depends on how sudden were the headaches, what are the type of headaches, is there a doubt in the actual diagnosis, is there a thought that this is actually not a typical migraine but actually something more severe. like an aneurysm in the brain, which is a blood vessel that could be expanding and becoming symptomatic, which, you know, that could happen when their blood pressure goes up, like if they're doing sports or something like that. So it's very important, first of all, to establish that it does sound like a migraine, that there's nothing unusual about this type of migraine. And there are many factors that any doctor seeing a patient with a potential migraine should be checking, including the person's blood pressure, including listening very carefully to the history. When did the headaches start? How did they start? How frequent are they? Do they wake a person up at night? There's all those factors, and also if a migraine start later on in life, from the age of 50 or maybe even a bit younger, we have a lower threshold for doing an MRI, for example. Right. And in a child, we may do an MRI as well. There are various things. I won't go too much into the MRI side of things, but it's important that people understand that it's sometimes, and maybe even fairly often, used to ensure that this is a migraine and nothing else. The other things that, then there are normal blood tests that people may get, which would be a full blood count, just to look to see if they're anemic, just to check their electrolytes, so their sodium, potassium, a few other things like that. And then some of the tests that I've learned to do that are not typically done, and we'll get into them a little bit more. One of them I check is something called the omega-3 index. And omega-3 is basically, these are fatty acids that are a part of the cell membranes, of the walls of the cells. And they're basically a part of the cell walls throughout the entire body, and no less in the brain. The brain is immensely made up of fatty acids, of omega-3 fatty acids, particularly DHA. Honestly, what the purpose of these is to make the cell membrane, the cell wall, more fluid. And so a cell wall can be less fluid or more fluid. And the more fluid it is, means it's usually they've got higher levels of DHA and EPA in those cell walls as constituents of the cell walls. And that means that the ions and other proteins can transfer between cells more easily. And there's an actual sort of fluidity, if you imagine that the walls are just a bit more fluid. And that means that messengers or messaging can happen much more simply, much more easily between cells. And there's obviously a sweet spot, should we say, where you don't want it to be low and you also don't want it to be too high. And there's reasons for that, but we can talk about that later. So one of these important ones I test is omega-3, and omega-3 is influenced by your fish intake. And it can also be people who are taking supplements. But you want, a lot of people who I test have a level of around 4%. And we know statistically and mechanistically that people really need a level of around 8%. And maybe up to 10%, 11%, 12% at the most probably. This is the sweet spot area. But many, many, many people have a level of around 4%, 5%. I see people with levels of 2%, 3%, very commonly.
This is the omega-3 index, Mike, what you're talking about. So, sorry, the omega-3 index.
Yes.
Yeah. Can you just tell us a bit? I don't know much about that. Can you just unpack that a little bit, please? So
the omega-3 index, it was developed. I can't remember the name of the doctor. He's an American. I think it's an American doctor. I think there was also one in Germany who developed the test. And basically, they looked at. They wanted to know, how do you measure omega-3? Now, typically, omega-3 could be measured, and it was looking at the level of omega-3 in the blood. And the problem with that test, as in the liquid in the blood, the serum. The problem with that test is it's telling you what the level is right now, but it doesn't tell you what's the person's level throughout the last few months. So a little bit like glucose and HbA1c. Glucose will tell you a spot measurement. This is the glucose level today. HbA1c is actually glycated hemoglobin. So what happens is that the hemoglobin, the red blood cells, the glucose has an effect on how those molecules, it has an effect on the red blood cell, let's say on the red blood cell membrane, and we measure that, and that looks at the last 3-month average, because the red cell life cycle is between 3 to 4 months. And so by looking at the level of glycated hemoglobin on the red cells, we are getting a measure of the average level of glucose over the last 3 months. In the same way with omega-3, we're looking at it on the red cells. And it's a simple
Right.
blood test, but it's looking at exactly the same. It's looking at exactly the same kind of thing. And as a result of that, you can see, okay, this person's average omega-3 over the last 3 months is X or Y. And accordingly, you can make a decision on how to manage things from there. So
Thank you.
Does that answer you enough?
Yeah, it does. I'd heard of it, but I wasn't really sure what it was. So that's very helpful. Thank you.
Okay. And there have been trials. There was in 2024, just a couple of years ago, there was a meta-analysis which actually looked at 40 trials with over 6,000 people, and it showed that people who have high dose of omega-3 beat even drug comparators, so people who were taking drugs for prevention of migraines, and reduced their migraine frequency. And in my opinion, it's really worthwhile knowing what a person's starting level is and what their end level is. So it's not enough to tell people, hey, go and buy cod liver oil or fish or just eat fish. You don't know if your level is low, and if it is low, you don't know how low. You don't know, it may be normal. There are some people have very normal levels, in which case you shouldn't be taking supplements for this. You don't need to. And you need to be looking elsewhere. So I think there is a huge importance in that. And there's also, even in the studies that are often done on this, those studies often don't test the actual levels of omega-3. So they just say, we gave this population this amount of omega-3, and this population didn't get omega-3, they got a placebo. But that doesn't really tell us, what levels were achieved for how long, etc., etc. So that's omega-3. The next thing I would say is to test people's magnesium levels, but there's a huge caveat. Magnesium is an incredibly important molecule in the body. It has about 300 different functions, at least in different enzymatic reactions. And it's probably the single most underused intervention and the cheapest. It's dirt cheap. In one sentence, low magnesium makes it easier for the electrical wave that causes the migraine to actually fire off. So what happens in a migraine is that on the outer surface of the brain, there's what's called a cortical spreading depression, which basically means that there is an electrical signal that's propagating in a specific way, and it's having effects on the blood vessels. And so having enough magnesium in the blood can actually increase the threshold that will actually happen. So it won't happen so easily. So the migraine won't propagate. Now, the problem is that the standard test for magnesium is not a good test, in the sense that most of the magnesium is stored inside the cells in the body, which means that if you do a blood serum level, that's the level of the magnesium outside of the cells, in the fluid of the blood, you're not actually seeing what the true magnesium picture is inside the cells. So you could have a completely normal magnesium level, but inside the cells you could be depleted. And this is something that happens chronically over a period of time. If you have a low level, you definitely have a low level. If you have a high level, you have a high level. But if you have a normal level, it could be normal, but it could also be low. And the upside of that, the good side of that, is that actually magnesium is incredibly safe to take for most people, unless you've got something like kidney failure. It's an incredibly safe supplement to take. And most people should probably be taking it nowadays. And as long as they're not getting side effects and they're taking a good form of it, it can be helpful. But
what would be the side effects if people took too much?
If someone's having too much magnesium, it can even have effects on the rhythm of the heart. And certainly you don't want to go down that route, okay? But in general, one of the earlier side effects would be someone having diarrhea, for example. And now there are certain types of magnesium that tend towards causing diarrhea, and then others that don't. One of the better ones for brain health, let's say, is magnesium bisglycinate, and there's another form called magnesium threonate. And they tend to we think that they're absorbed better into getting past the blood-brain barrier and being absorbed and being used in the brain. So that's magnesium. Again, there's been a meta-analysis, I think also in 2024, and it showed a reduced frequency and severity and number of migraine days that people suffered in a month. So that's magnesium.
So if I take an extra 300-400 milligrams of magnesium a day, that's a very safe thing.
It should be fine, yes. And you can check it. You can check it after taking it for a month or two. You can actually check your level. It's very, very hard, unless you've got a problem with your kidneys in general. It's very hard to overdose on magnesium. It's very hard to get a high level. The body will usually it has hemostatic it has mechanisms to make
homeostatic,
has homeostatic mechanisms that will prevent a build-up of magnesium, basically. So it will usually take what it needs, and then it should normally pump the rest out.
A common deficiency in an underused treatment. That's very interesting.
I think that's a very important one. Another thing, iron, which we usually see in the body as ferritin, which is a protein attached to iron. And the question isn't whether the iron or our ferritin levels are within the range. The question is, are they at an optimal level within the body? And the strongest evidence for this is in women, especially with what's called menstrual migraine. So women who tend to have migraines around their menstrual period. Last year, actually, they did a review looking at iron deficiency anemia. And it showed that people who had an iron deficiency anemia had something like a 75% higher risk of having chronic headache. And without going into too much detail, the mechanism affects dopamine signaling and also sleep quality, and they both feed into migraines. There's a number of different factors that lay the groundwork for a migraine, shall we say. And iron is also important because the way in which energy works in the cell is partly because of iron. Iron allows the cycle of oxygen being used up by the cell, and the production of energy has to go through iron. So people who are deficient in iron have a predilection towards many things, but one of those things is migraines. And you can have a normal blood count, you can have a normal hemoglobin level, and all the indices in the blood count can look normal, but you can still have a low iron level. And so it's very important to ensure that is a good level. And if it's not, you need to know, this is going a little bit off subject, but you need to find out why it's low in the first place. It may just be dietary, it may be because a woman is having heavy periods, but it's important to establish the reason for it and not just to say, I'm going to take iron, right? We should know why we're treating people's iron deficiencies.
I don't think it's off subject at all, Michael. I think it's holistic care.
Sure, but I don't want to, trying to focus it on the migraine side.
Yeah, sure, yeah. So I'm probably not helpful at all.
The next thing, in terms of your question, checking people's levels of B12, folate, homocysteine. So when B12 or folate are low, the level of another chemical in the body called homocysteine goes up. And there's a pretty simple causal chain that high homocysteine can cause dysfunction of the blood vessels, which activates the nerve pathway that drives the migraine pain, which is without being too technical, something called the trigeminal system. So the trigeminal nerve is a nerve that basically feeds into the face and the side of the head.
Three-pronged nerve,
It's got 5 branches.
5, sorry.
And there are a lot of blood vessels that are related to that. And the nerves actually control the blood vessels, how well they work. So, high homocysteine levels has an effect on the actual blood vessels in that system. So it's very important to keep homocysteine lower, and one of the ways we do that, or two ways we do that, is making sure that people have adequate levels of B12 and folate. I'll get into that a little bit later in terms of actual the kind of things that people should think about taking, but again, this is not direct medical advice. This is stuff that you can take to your doctor and discuss. This is,
absolutely.
it doesn't replace that. This is really educational. That's the purpose of this.
Entirely. Yeah.
The dose of, for example, folate, though I will go into that because it does actually matter. Many people take folic acid, partly either because of pre-pregnancy or during pregnancy or after pregnancy, and sometimes as part of a multivitamin. And it's actually been shown very clearly that the dose for migraines needs to be about 5 times higher. So the standard dose of folic acid is around 400 micrograms per day. In some pregnancies, they say to use 800 micrograms. And both of these levels are less than 1 milligram. The level of folic acid that actually is seen to work in trials is 2 milligrams, which is 2,000 micrograms. So and they actually showed a study where they tested it at 1 milligram, and which is still a significant dose, but it didn't make the same effect. And when people were taking a 2 milligram dose of folic acid, it actually reduced over a few months the frequency and the level of migraine disability, let's say, dropped from 60% to 30% at about 6 month period, about the 6 months mark. And as I said again, the half of that dose didn't have an effect. So most people are taking a dose that's way too low to help.
Wouldn't it be interesting if we had a comparative study between methylfolate, the natural form of the vitamin, and folic acid, the synthetic form? Yeah. I strongly suspect the natural methylfolate would be more efficacious.
I always tell people to take methylfolate.
Yeah.
The other thing to say is that there's a genetic variant called MTHFR. I'm not going to go into too much detail, but it basically impairs the processing of folate. And it's relevant in people who get an aura with their migraine. Aura is when you get these sensations beforehand. You may see lights, you get funny smells that you notice, and it's a test worth knowing about. Some people have this gene variant, and certainly if someone's got a migraine with aura, it's worth thinking about. Taking methylfolate may be something that can help in that situation. Another thing, vitamin D. So this is probably more commonly tested, same as folic acid and B12, I guess, but there's a clear association between a vitamin D deficiency and migraine burden. So getting people's levels up to really an adequate and optimal level is important. And you wouldn't normally, if the person's not deficient, there's no point in supplementing it. So if they've got a decent level of vitamin D, it's not like if you take huge doses of vitamin D for long periods of time, it's going to make a difference. It won't. It's certainly not something that everyone should just be taking in the event that they've got migraines. If they've got a level of vitamin D in the range, I would say probably around 40 to 50, maybe 60, they don't need to take vitamin D in addition.
We're talking milligrams.
Sorry, I'm talking about nanograms per deciliter. So there's
nanomoles per liter,
and there's nanomoles. So the nanomoles is you times that by 2.5. So you're talking about a level of if they've got a level of around 120, 125, that sort of level, that's more than adequate. That's fine.
Right. A lot of people don't have a level of 125 nanomoles per mil. That's for sure.
Absolutely not. So these are all things that need to be optimized. The next thing is thyroid. So people who have underactive thyroid, which is the gland that sits in the neck and that's highly responsible for metabolism, even if they have a very mild or what's called a subclinical hypothyroidism, so it means that their thyroid is underperforming. This is an amplifier for migraines. It makes it, if you can control the thyroid and get it working better, you will usually improve the severity, meaning you'll make it less severe.
So it's normally hypothyroid rather than hyperthyroid.
It's usually hypothyroid, yes. And the tests that usually should be done are not just the TSH, but also the free T4.
Yeah.
Often TSH is done by itself. Free T4 gives a bit more information.
Very rarely done these days, I must say.
Yeah, you'd have to ask for it. I can say that I've seen people who've had migraines for years, and when their thyroid was treated correctly, the migraines really subsided substantially.
Yeah.
Next thing,
we seem to over-rely on TSH these days rather than doing T3, T4, which is a pity.
And TSH is a very good test, but normally, by the way, if the TSH is high, which means that the thyroid is underperforming, paradoxically, the labs normally should add in automatically a T4. But I can't say that that's always the case. It's something that needs to be checked.
Don't think it is.
Another thing which is not commonly checked, and I'm not saying that everyone needs to check this, but zinc, for example, it's cheap and there is some evidence that it can be helpful. So if they can do the test, great. If not, I can tell you the usual dose that can be given that's a very safe dose, and that's around 25 milligrams a day. You don't want to go higher because over time it can cause copper deficiency. So you want to avoid doing that. And just in terms of being complete about the test, said doing a full blood count to check to see if someone's got a problem with if they've got an anemia, even if it's a mild anemia, because even a mild anemia can destabilize the threshold of the brain, the electric threshold, which can then result in a headache being propagated more easily.
Amazing. So such simple tests, simple supplements to think about. And if we correct all these, we can massively help the total burden of migraines just by such simple interventions.
I have seen this time and time again, to my own surprise, by the way. I never used to work like this years ago, and only over time, by reading through stuff and seeing how patients respond, I've definitely come to the conclusion. I can tell you, I can tell you stories, just amazed me. I literally
do give us an example.
Just the other day, I had a patient who I saw a few months ago, and he's a young chap. He's around 28, if I recall, and he's had migraines since he was basically a young teenager. And he was put on everything within reason, and I think probably at least a year or two ago, he was started on an ACE inhibitor, which we'll talk about there. ACE inhibitors are medications that are used for blood pressure. And it turns out that one of the effects of some of these ACE inhibitors is that they can actually reduce the frequency and the severity of migraines. So he was put on that, and it helped. It definitely helped him. And I'd never met him before. He moved to my practice. And I was just asking him about, because I'd never known him before, and we did some basic blood tests. And I said to him, look, I think, you've been suffering with migraines for years. Have you ever had your omega-3 level checks? And he hadn't. He had this test done. He had a level of around 4%. And I told him to start eating sardines and supplementing a little bit. And he got his level up to, it was at least 8% he got his level up to. And I saw him, this was around 6 months later, again. And he basically said his migraines have virtually stopped. Wow. And he had, and he was hesitating about taking the ACE inhibitor. But when he was on the ACE inhibitor alone, he was still getting the headaches. He was still getting the migraines. And he did actually lower the dose now. He was taking lower doses. He was barely getting anything that resembled anything that he used to get. And again, this is a factor of time. So I'm hoping that with more time, that could improve things as well. And another chap I saw just recently who has been suffering with awful migraines for years, vomiting profusely. And headaches that would go on for days. And he's also taken on board some of these measures. And I'll talk about another important thing, which is sleep, which is incredibly important. And he is not, he's not migraine free, but he is a lot better. He stopped vomiting profusely. And he's much more able to function as a result of it, because once you get into the cycle of vomiting, you can't even take medications. That's also a problem. So these are just two people that come to mind right at this moment.
It's impressive, yeah. Going on to sleep, Michael, I mean, sometimes I don't have the time.
So, okay, so if we're talking about sleep, people need to understand that sleep is not just going for a rest, okay? It's a restoration of neurological function. There's a lot of things that happen at night during sleep. Sleep deprivation lowers the threshold of the brain for migraine triggering electrical waves to occur. I think people really need to be asked in detail what is the quality of their sleep, because if you ask most people, they say, yeah, I sleep, and you ask them how long, they say, I sleep about 6 hours, maybe 7 hours, maybe 5 hours, and there's a lot more to it than that. But we see that sleep can, you can have varying qualities of sleep. That can be affected by just by going to sleep late, by having a very hectic timetable. It can be related to stress. People can have very broken sleep. People with iron deficiencies can have what's called restless leg syndrome, where they actually start moving their legs at night, and that causes disturbances to their sleep.
I used to get that every time I worked night shift.
Really?
About 2 o'clock in the morning, I just couldn't. It was horrible. It's like ants crawling all over your legs. And you know, but not every night, but you know, probably about 50% of night shifts I used to get that, and I just used to walk up and down the corridor all night. It was
right.
Yeah.
It's very disruptive. Other people.
You couldn't get to sleep with it.
Yeah, and it's actually it very often responds to iron treatment, by the way.
Interesting. Right.
Usually intravenous iron treatment. That's my experience of it, at least. Some people respond also to oral iron treatment. Very often intravenous iron treatment gets their levels right up, and it helps dramatically. To get back to sleep again, there's also the subject of what's called obstructive sleep apnea,
yes,
which a lot of people think, oh, it's only people who are very overweight or in certain particular situations that get this. It's certainly not true. I can tell you about a patient I had also just seen the other day, but I've had this patient for the last few years, and recently we discovered that he was developing signs of arterial disease, of heart disease. It was in his the arteries in his neck. Maybe we'll do a video about it sometime, or I'll direct people to the video on my channel that I'm doing about this particular case, because it's really fascinating. And he actually had a sleep study, and the sleep study was reported as normal, or not normal, but mild obstructive sleep apnea, which is something you wouldn't normally treat in any way. So basically kind of snoring, and there's a mild obstruction to the airways, so the oxygen level was going down a little bit, but not anything dramatic at all. The thing is, with him, it was actually going down multiple times, like non-stop. It was just happening throughout the night. And that in itself can be more damaging than someone who's getting it's going down further, but it's not happening as frequently. So just to say that sleep apnea is incredibly problematic in terms of migraines. About 1 in 6 people who have obstructive sleep apnea have migraines. Right. It's not just a morning headache, it's a migraine. As I was talking about the repeated oxygen dips, so the oxygen levels that go down, there's a few things that happen. Oxygen goes down, carbon dioxide goes up because you're hypoventilating, you're not breathing as well, so you're actually not clearing off carbon dioxide as well. And that causes an instability in the nervous system, in the blood vessels, and that's also a trigger for migraines. We know that treating obstructive sleep apnea with CPAP, which is continuous positive airway pressure ventilation, so it's wearing a particular type of mask attached to a machine, and that pushes the air in at higher pressure, and that keeps the airways open, that reduces migraine frequency as well. And it's really important to mention this because a lot of people would never know that they had this. And there are some telltale signs that you can ask them in their history. There are some classic signs. If they are loud snorers, if anyone's witnessed them having pauses in their breathing during the night, if they wake up very unrefreshed on a regular basis, daytime sleepiness. But honestly, anyone who's got a chronic migraine and who hasn't had a conversation with their doctor about this, it's really important they do. There are very simple tests that can be done. There's a home sleep study today that exists that you literally put it on your finger and on your wrist and a little sensor over here, and it measures about 7 different parameters, including which position you sleep in. So why I was telling you about the patient before, the one who was getting lots of dips in his oxygen levels, this chap, it was fascinating to see his sleep study, because his sleep study, when he was lying on his back, he was having all of these dips non-stop. When he was lying on his side, almost none. So the cure for him, I told him, tie a tennis ball to your back on one side, and then you'll sort of subconsciously notice it in your sleep.
So simple.
You know, we haven't done the repeat experiment on him yet, but he's going to do it, and I'll update you with that. But you know, that's a case of treating a heart disease with a tennis ball. You know.
No, well, yeah, it makes perfect sense. I mean, as well as that, you know, when your oxygen dips, it's actually when your oxygen dips, it's actually going to increase the blood supply to your brain, isn't it? And you're going to get all sorts of vascular effects. I like that. Keep it as simple as possible. I love that. Tennis ball treatment. We'll have to do a
sleep
video on
apnea
tennis
is
ball
very,
treatment.
very important.
Yeah.
And then there's more
So just before we move on, Michael, I really had associated that with being overweight. So you can have a normal body mass index and still get sleep apnea.
Yeah.
Right. It's just more common in people who are overweight.
Sleep apnea can be caused for various reasons. You've got what's called peripheral sleep apnea, which is happening because of something going on with the literally being overweight perhaps, and that's actually causing literally a weightiness on your chest. When you're fast asleep, when you're in deep sleep, your muscles are more relaxed, including your neck muscles, and as a result the airway can collapse. And there can be other reasons, which I won't go. There are loads of possible reasons as to why the airways can obstruct in the wrong situation. It can be positional. It can be that there's, as I said, the muscles are more relaxed when you're in deep sleep. If someone drinks alcohol in the evening, that in itself has a relaxing effect on those muscles, and it can make them more likely to collapse their airway. There are various reasons. Then there's what's called central sleep apnea, which is a product of things that are going on in the brain, having effect on those muscles as well, or in just the respiratory patterns. So it's very, very important to consider this as a possibility, and certainly in someone who's having chronic migraine. And then if I'm moving on, there's other things that are very important that need to be thought about. Hydration. We know that people who are dehydrated have a greater propensity, so it's important to drink enough, not to overdrink, don't go crazy, but drinking sort of 2 litres, 2.5 litres a day, assuming you're not sweating out loads from sports, in which case you may need significantly more. Caffeine is also important. It's important to see the pattern of how much coffee or tea a person is drinking. Caffeine in itself can actually prevent migraines if it's had at sufficient levels. Very often when people stop drinking, that can produce migraines as well. They get a withdrawal from caffeine, that can lead them onto headaches. And alcohol as well, we mentioned it before briefly, but alcohol is a vasodilator, so it makes the blood vessels widen up. And it also causes dehydration, and in itself it can cause sleep disruption. So through various mechanisms, alcohol can also be a significant factor in the progression or the beginning of migraines. Do you want me to talk now a little bit about the medications that are used as well?
Let's talk about medications. You've already mentioned ACE inhibitors, these angiotensin converting enzyme things. Normally you associate that with heart failure and lowering blood pressure.
Right, and that's what they're used for, and certainly for people who've got high blood pressure already, and sometimes also people who've got kidney failure, they can also at the right doses they can be used to preserve kidney function as well, but also to preserve cardiac function, heart function. So there's ACE inhibitors, and then there's something that works a little bit further down the line called angiotensin receptor blockers, which the stronger evidence is in one that's called candesartan, in 2003 in the Journal of the American Medical Association, JAMA, they did a trial that showed about a 30 to 40% of people who took it had more than a 50% reduction in the migraine days. And I think they had a similar trial in Lancet Neurology. Now, the thing I want to say about this is that these medications can be very helpful. There are others as well which we can get into. Actually, I'll get into them first. There's something called CGRP inhibitors. So calcitonin gene-related peptide, which is a pain signaling molecule which is released during a migraine attack. Now, this is a relatively new medication. It's been out for a few years, and it basically blocks the propagation of the migraine. And it's genuinely effective, and it's a real advance for people who suffered terribly. But to stand back for a second, again, to come back to the upstream question, why are we needing these medications? And we're needing them very often because all the other things are missing, or some of the other things are missing. And if you do, this is not to say that everything is curable by making sure that all of those other things are in place, but my experience certainly has been that people who have all these other factors in place have a much lower propensity towards having migraines. Much less things can trigger one of these migraines, and I think that really has to be the way forwards. So, we're talking about simple, safe, cheap interventions that, or changes in the way we behave that really can make a huge difference.
Mm-hmm. Absolutely, yeah. If we can prevent it and optimize physiological health, of course, that's always better than pharmacological interventions.
Yeah.
Absolutely.
There's a couple of other things to mention. Hormones. So women who have menstrual migraines.
Come across this. I've seen this a lot.
Yeah, it's very, very common, especially, and it often happens, by the way, around menopause. So you do see younger women who get this, but very often women who've been fine all their life, when they go through menopause, that because of the withdrawal of estrogen from the body, it's a very potent trigger for CGRP, for this calcitonin gene-related peptide. And also in the cycle, in the menstrual cycle, when there's a drop in estrogen in what's called the luteal phase, that can also result in migraines. And probably partly for cultural reasons, a lot of women are told, look, you just have migraines, and there's no conversation really about the cycle, about contraception, because that can help, or at what stage they are in terms of the menopause. Many women start going through the menopause 10 years before they actually have a change in their period. So they start having perimenopausal changes in their hormones, which can be very difficult to pick up because when you do the test, they're pretty much normal. And so it's another thing to take into consideration. Another thing I wanted to mention is a couple of supplements. One is vitamin B2, riboflavin. Okay. And there is it's a cheap supplement and there's good evidence behind it, and it's very rarely used, unfortunately. The dose that can be used is 400 milligrams per day, and that's supported by the American Academy of Neurology. And the hypothesis to how it works is that migraines, when we're talking about all this stuff about energy transfer in the cells and everything, migraine propagation happens because of an inefficient production of energy by the mitochondria, which are these small subcellular units that are basically, we call them little batteries, but there's much more to them than that. But for the purpose of this talk, that's what they are. And it's known that riboflavin, vitamin B2, is important in the electron transport chain, which is the transfer of energy within the cell and the production of energy. And there was a trial done probably about nearly 30 years ago where they had about nearly a 60% rate of response versus 15% in the placebos. So people who didn't get it. The important thing that people need to know about it is that it turns the urine bright yellow. It's completely harmless, but they should know about it in case they panic. Yeah. And another supplement that could be helpful is coenzyme Q10. Oh, right, and a similar mechanism as riboflavin, as vitamin B2. And taking coenzyme Q10, the dose is, if you take ubiquinone, it's usually around 200 milligrams a day. And that can also improve the frequency and duration of the migraine attacks. And it's fine to use these things together. And then on another note, there are things called neuromodulation devices. So people who, despite all of this, are still suffering with migraines, there are a couple of actual devices that exist today. I just want to make it clear, I haven't got any financial affiliations with any of these companies or whatever.
Neither have I.
And I don't even have to mention the names. But there's two devices that come to mind that I've used and patients of mine have used. One is called Kefali, and it's a device that basically sits here on the forehead, and it causes an electrical stimulation, and that can be used during for prevention of migraines and also during migraines to abort an attack. And some people have found it very, very effective. And it's basically causing a stimulation of the trigeminal nerve from the skin, so it just sort of sits there. And the other one is a device called gamma core, which is a vagus nerve stimulator, and it sits here on the neck. It's a handheld device with a battery in it. And it can be used in migraines. It's funny because it was developed for, I think the market that they developed it for, is to use that word market, but the patients that it was developed for was for people who've got migraines, because migraines are very, very common. And this was a way of having a drug-free, very safe device to prevent or treat migraines. And the irony is that it turned out it does work for migraines, mainly for treating a migraine in progress. But the thing it was designed for was the migraines, because there's so many people suffer from migraines. But the thing that it really works for quite well is cluster headaches, which are incredibly rare. So the let's say the business model got turned on its head a little bit. Yeah. But the point is that it can be used for migraines, and it sits here on the neck, and you turn it on, you turn it up according to the instructions to a level that's comfortable, but that causes a stimulation here. And that you do it for maybe 2 minutes, and then you do it again for 2 minutes. There's a little protocol that you can use for it. It's been cleared by the FDA, by the Federal Drug Administration in America. As has, I think, carefully the other device that goes over here. And it can be very effective.
I think cluster headaches are really overdiagnosed because, as you say, you very rarely see it. And I think GPs, so they often think cluster headaches when it's actually migraines.
Some people, that's the case, yes.
Yeah. Would this vagal nerve stimulation be useful for anxiety as well?
It probably is. I have read some research on it in the past, but I can't. I'm not going to give you a rundown of that because I can't tell you exactly how useful. I mean, vagus nerve stimulation can be used for anxiety. It probably be used for other things as well. It's still in its. I won't say it's in complete infancy, but I think in terms of, if you look online, you'll find all sorts of devices that they claim are going to work for anxiety, whatnot. I don't know how well they've been proven yet. There is good mechanistic thinking behind it. The question is, does it work for, and at what level? But I don't know the answer to that.
I just like the idea. It's such a simple intervention. And of course, it might be a good idea to make sure your doctor hasn't got shares in the company, so he's giving you an objective medical opinion.
Yes, yeah.
No, I really like it. It's basically physiotherapy, isn't it?
It's a kind of did you say physiotherapy?
Yeah, physiotherapy.
Physical therapy. It's a physical therapy, and it makes sense physiologically, so yes.
Yeah. So, how do you put all this into one practical framework? I mean, we've covered a lot of ground here. How can you kind of summarize this a bit?
Well, as to do a kind of summary of what we've spoken about, there's the blood tests, including the omega-3, magnesium, iron, B12, folate, homocysteine, vitamin D, thyroid function, full blood count. If someone specifically has migraine with aura, then it's to consider having an MTHFR test. And if they're positive, to start taking methylfolate, which anyway I would have said to take methylfolate one way or the other, but then it can be a matter of dose as well and trialing it. Supplements, magnesium, riboflavin, which is vitamin B2, coenzyme Q10, folic acid at 2 milligrams, not 400 micrograms. Sleep, getting a proper history, what's going on with their sleep, and have a low threshold for a sleep study. And that doesn't mean going into hospital for a study. There are home kits that can be used today that are really very, very good and that can pick up most problems in that regard. Hormones for women, mapping the pattern of the hormone changes during the month, the migraines, I should say, during the month, and then by extension, understanding what might be going on with the hormones, and that can happen at different stages of life. Medication, as I said, ACE inhibitors, angiotensin receptor 2 blockers, especially if someone's got blood pressure already, or they've got high blood pressure. And then there's the devices that I mentioned, the Kefali, which is the trigeminal, the forehead stimulator, or Gammacore, which is the vagus nerve stimulator. And they're especially useful when someone has got an intolerance to medication or overuse is a concern.
Really is a practical way forward, isn't it?
Yeah, and the fundamentals, I said, good hydration, keeping caffeine. Coffee in general, I think, is healthy, but it's about not having huge swings in your coffee intake. So, and probably for some people seem to be more caffeine sensitive. So, for many people, they find that if they have coffee after 2 o'clock in the afternoon, it can disturb their sleep. And there's some people who they don't think it disturbs their sleep, but actually it can disturb their sleep architecture. And then when things are pretty severe, if nothing else works, it's good having to hand a triptan medication, which is like sumatriptan or rizatriptan. They are very good at aborting a migraine very quickly, as long as you catch it very quickly. So even at the earliest stages.
And again, they're affecting the blood supply to the outer part of the brain, aren't they?
Yeah.
Any particular analgesics you like to use if you need to? Well, what painkillers? I found that morphine's pretty useless for headaches and codeine. Is there any you find particularly useful? I gave
someone morphine for a migraine.
No, that's probably why they don't work.
Sometimes things like codeine, which can be mixed in with other analgesics. There are combination medications of codeine, paracetamol, which is acetaminophen, and caffeine in a single pill. And that can work very well for people. I tend to try to avoid as much as possible, but you can't always avoid it, medications containing non-steroidal anti-inflammatories.
That's the ibuprofen type thing.
Many people use ibuprofen. And ibuprofen can be very effective even for stopping a migraine for some people. And very often there are forms of ibuprofen, Nurofen, Advil, it's known as, which include some other things like paracetamol or caffeine. The problem with a lot of medications that people who use medications a lot can also develop medication headaches. So the drugs themselves, taking them regularly, can actually cause headaches and can be a huge problem to come off using those drugs. And then you can't separate what's the initial migraine and what's the actual, what's causing what.
Yeah.
So it's incredibly important, as I say, to try to get the other things in position first.
Do you ever find that foods are a trigger?
Fruits?
Different foods, like migraine after eating cheese.
Cheese is known because of tyramine, I think, in the cheese. Wine, chocolate. But people have different triggers. So these are the classic ones. But a lot of people, it will just happen because of stress. And these things are multifactorial migraines. They usually, there's a whole bunch of things going on. A person who is not getting enough magnesium in their diet, and many of us are not, full stop nowadays. People who are stressed, who are getting insufficient sleep, the effects carry up. So they basically, it's not like, it's not one event, it's a whole series of events over a period of time. And then if you mix in things like hormonal changes, alcohol, whatnot, or you're basically creating the perfect storm for these things to happen.
Yeah. Amazing. Very thorough, Michael, of course, as always. Where can we learn more about what you do?
Well, I've got a YouTube channel. It's called The Accidental Doctor. It's The Accidental DR. It's the handle. So by all means, come and see that channel. And I'm doing more and more videos now. There's a lot of things that I'd love to impart after close to 30 years working. That I just feel like there are so many things that get missed.
There really are. I mean, I've been working with patients with migraine pretty well all my life, and there's so much there I didn't know. It's just absolutely mind-blowing. And so many patients, people I know personally who've been to the doctor and get none of this. And it's so simple. I mean, we're in a society now where there's ultra-processed foods. People don't eat much natural food. Big agriculture's putting lots of fertilizers on, losing the trace elements from our food. Food is not as nutritious as it was. all these lifestyle things are just tying in, and human physiology just can only work in particular parameters. And if we ask it to work without the nutrients and the parameters it's not designed for, surprise, surprise, it goes wrong. And we just get back to these really simple, basic health promotion, disease preventing strategies, and then occasionally, if we need to, let's use some heavy duty drugs as well, by all means.
Yeah, I mean, it's a very good point that you mentioned, and obviously even the things that I said in terms of the vitamins, if you can manage to get these things in sufficient quantities from your diet, that's the ideal. And again, even with omega-3, that I'm quite a big proponent of it for various reasons. I always try to get people to get their levels up through eating fish.
And of course, vegetarians can eat marine phytoplankton omega-3. There are alternatives.
That's also possible. That's where the fish get that's where the fish actually get the omega-3 in the first place.
A lot of people don't know that fish don't make omega-3. They actually get it from the plants that they eat. So you can go directly to the marine phytoplankton and get the supplements directly from there. In fact, I know some people that prefer that because they're a bit concerned about contaminants in fish, such as mercury and other heavy metals.
Right. The really good supplements, if you're going to go that way, the really good ones have they usually go through a process of refinement where they actually ensure that those things don't occur. But the other thing that can happen with the supplements is that they can get oxidized, and you wouldn't necessarily know it. So you could be taking a good quantity, a good dose of omega-3 from a supplement, but if the actual supplement itself is even partially oxidized, it's working against itself. So you're kind of like, you're getting the goodness out of it, but it's simultaneously potentially doing harm.
The correct thing to do, they get one of the capsules.
Sorry?
Yeah, if you cut one of the capsules open and it smells fishy.
For sure.
It's probably oxidized.
At least, yeah.
Or if you get sort of lots of fishy regurgitation after taking it, it's probably oxidized.
Yeah.
But no, I mean, I think marine phytoplankton really is part of the way forward for world nutrition. Actually, it's such a healthy nutrient. It's a pity we don't do much more of it. And of course, in some Asian countries, they eat a lot more seaweed than we do in Western countries. So, a lot to learn from the natural hunter-gatherer approach to diet, I think.
And on the note of fish, I generally tell people to avoid tuna. It's a bottom feeder. It eats a lot of other fish, and it accrues a number of different toxins: mercury, PCBs, dioxins, if you're doing this through eating fish, the safest is sardines, salmon. Preferably in brine.
I'm also experimenting growing duckweed at the moment. I don't know if you can see that. But duckweed grows on fresh water. The reason I'm just doing a few different experiments on this, we want to grow it up at huge scales in Africa and feed it to the chickens. And then the chickens will put the omega-3s into the eggs. But having said that, you can eat that directly, and this does contain omega-3s. I don't know about the DHA EPA profile, but I know it's a heck of a lot better than not getting any, and it's vital for brain development, of course, which is again a common problem in poorer areas. So just a sideline, completely irrelevant, but one of the things I'm working on at the moment. And people keep asking about the plants. So at the moment I'm experimenting with this is Artemisius annua, which, as you'll know, of course, Cohen won the Nobel Prize in 2015. And does treat malaria and probably maybe cancers as well. So
really,
anyway, enough of my eccentricities.
That I need to read about.
Michael, thank you as always. Do check out The Accidental Doctor on YouTube. Lots more content, and as far as I'm concerned, these videos should be compulsory for all GP training, but that's just my view. But thank you very much.
Well, I wish I knew some of the things I know today at the time when I was training. A lot of it is also stuff that develops over the years, It
is, but you're right. You get a feel for it. You get this kind of tacit knowledge, and I think it's so important that experienced practitioners like yourself are so able to communicate this and teach it. You could give young doctors, young nurse practitioners, whatever it is, real medical officers in Africa, give them real insight because of your experience that can save lots and lots of human suffering. You know, if we could start our career, but there again, we all look back at the start of our careers and cringe, don't we? But if we can learn from other people's mistakes and other people's development, so much the better.
I mean, I think a lot of it is also that there's just so much limitation on time in consultations nowadays that it's very difficult to deal with all of these different factors. But you know, hopefully through time, education, people can come more prepared to consultations that can help them greatly to come to, it helps their doctor to help them.
It does.
So, you know, if you came with a list of things that you think are relevant to you for whatever problem, and you work, and I'm not talking about Googling every illness under the sun, but but actually just coming a little bit prepared, writing things down, that can be helpful. You're actually helping your doctor to help you.
Yeah, couldn't agree more. Great. Thanks, Michael, and let's talk again soon. And you've whetted my appetite for all sorts of other questions now, but for now, thank you very much.
Thank you. Take care.
You too.